In this video, here's what we'll cover. What OCD really is. Obsessions versus compulsions. The many faces including Puro. The OCD cycle. What ERP is and why it's first line. What treatment looks like and when to seek help. When most people picture obsessive-compulsive disorder, they see scrubbed hands and a tidy desk. That is only a sliver of the truth. For many of the people I sit with, OCD lives quietly, in unwanted thoughts, in hidden mental rituals, and in an exhausting search for certainty no one else can see. Here is the kind of story I hear often. A new father, holding his baby daughter, is suddenly hit by a horrifying image. What if he dropped her? What if, somehow, he wanted to? He feels sick, because he loves her more than anything. So he stops trusting himself to hold her alone, and he starts checking the locks, the stove, and most of all his own mind. From the outside, no one would call that OCD. There is no obvious ritual, just a quiet war inside his own head. So, what OCD really is, beyond the stereotype, it affects roughly 2 to 3 in every 100 people over their lifetime, and it is not a personality quirk or about liking things neat. The diagnostic manual defines OCD by 2 core features: obsessions and compulsions that are time-consuming, for example more than an hour a day, or that cause real distress and get in the way of daily life. Hand washing is just one possible compulsion, not the definition. What unites every form is the cycle, not any single behavior you could spot from across a room. Let me separate 2 words that get used loosely. Obsessions are unwanted, intrusive thoughts, images, or urges that push their way into the mind and cause distress. It might be a fear of contamination, a taboo image, or a doubt about whether the door is locked. The person knows the thoughts are their own, yet feels unable to switch them off. Compulsions are the repeated actions, or mental acts, a person feels driven to perform to reduce the distress. They can be physical, like washing or checking, or mental, like counting, praying, or reviewing memories. And here is the trap. Compulsions work, but only for a moment. That brief relief is exactly why they are so hard to give up, and exactly why they keep OCD alive. OCD wears many disguises, and recognizing your own pattern is often the first relief. It shows the problem is OCD, not a flaw in your character. Common themes include contamination, checking driven by a fear of harm, and a need for symmetry. And there are taboo or intrusive thoughts about harm, violence, or blasphemy, which horrify the person precisely because they clash with their values. There is also what people call puro, short for purely obsessional. Here the compulsions are mostly mental or hidden: silent reviewing, reassurance seeking, mental checking, so there are no obvious rituals to see. Despite the name, the compulsions are still there, just underground. The content matters far less than the mechanism underneath, which is the same across every subtype. That is why the same treatment helps. To beat OCD, it helps to see how it traps you. The cycle has 4 steps. First, an intrusive thought, the obsession. Second, anxiety spikes, the body's alarm fires, and the distress can feel unbearable. Third, a compulsion or avoidance, to make the feeling stop. And fourth, brief relief, then return. The anxiety drops, and the brain quietly learns, that ritual kept me safe. So next time the urge is even stronger, and the loop tightens. Every compulsion, every avoided situation, teaches the brain the obsession was a genuine threat. Reassurance does the same job. It stops the fear before it can fade on its own. But this is hopeful, not bleak, because OCD is kept alive by what we do in response to obsessions. Changing that response is what sets people free. That is what ERP is built to do. Exposure and response prevention is a structured form of cognitive behavioral therapy. Exposure means gradually facing the thoughts or situations that trigger your obsessions, starting with easier steps. Response prevention means choosing not to perform the usual compulsion while you sit with the discomfort. Here is why it works. When you face the trigger and resist the ritual, anxiety rises, but not forever. It peaks, then falls, all on its own. Each time, your brain gathers new evidence. The feared outcome did not occur, and the anxiety passed without the compulsion. ERP is collaborative, never being thrown in the deep end. Together we build a ladder of triggers, from mild to most distressing, and work up it at a pace you control. And ERP is genuinely first line. A landmark trial found it helped the large majority of participants, far above placebo, and held up well over time. Alongside it, acceptance and commitment therapy and mindfulness help you change your relationship to intrusive thoughts. Noticing a thought as just a thought, not a command or a fact. I draw on all three. So what does treatment actually look like? We start by mapping your specific obsessions and compulsions, so your own cycle makes sense. We build your trigger ladder and work up it, in session and through agreed home practice. Towards the end, we consolidate your skills so you can be your own therapist. Many people notice meaningful change within a few months of consistent work. The aim is not to never have an intrusive thought again, because everyone has odd thoughts, but to rob those thoughts of their power. A quick word on medication. For some people it helps, often alongside ERP, but psychologists do not prescribe. I provide the ERP therapy. I do not prescribe. Decisions about medication are made with your GP or a psychiatrist, and I am glad to work alongside them. So, when might it be time to seek help? If intrusive thoughts keep returning and cause you distress, if you feel driven to perform rituals or seek reassurance, or if these thoughts take up a large part of your day, please remember, having a disturbing intrusive thought does not mean you want it or will act on it. Those thoughts feel so awful precisely because they clash with who you are. And if your distress ever brings thoughts of not wanting to be here, please reach out now. Please reach out right now to Lifeline, your GP, or emergency services. You do not have to face this alone. OCD is common, misunderstood, and very treatable. With ERP and the right support, the thoughts can lose their grip. If any of this resonates, help is available here at Potentialz Unlimited in Bella Vista. You can read the full guide, or book an appointment, using the links below. Before you go, here's a quick recap of what we covered. What OCD really is. Obsessions versus compulsions. The many faces including Puro. The OCD cycle. What ERP is and why it's first line. What treatment looks like and when to seek help. And one small thing that really helps more people find this. Subscribe for weekly mental health explainers. Like this video if you found it helpful. Share it with someone who might need it.